Hello, my name is Lynda Ostermann. I'm a second-year resident at Mount Sinai Medical Center. Today, I'm going to discuss with you an interesting presentation of Kikuchi-Fujimoto disease. Kikuchi-Fujimoto disease is a rare condition more prevalent in women of Asian descent. The etiology of this disease is postulated to be due to many viruses, but is still unknown. The most common symptoms are fever and cervical lymphadenopathy, but rash, arthritis, fatigue, and splenomegaly can also occur. Even though most patients with Kikuchi-Fujimoto disease have normal blood counts, this is not always the case. Excisional biopsy is often recommended, especially to rule out other conditions that can resemble Kikuchi disease. Fortunately, most of the cases are self-limiting, but some of them might relapse. A 24-year-old Filipino male with a past medical history of non-alcoholic fatty liver disease presented to our ED complaining of submandibular swelling. He was found to have a non-tender left submandibular mass of rubbery consistency located at the left jawline. There was no erythema, edema, or any signs of infection. The patient stated that the mass recently started to grow and had progressively grown within the past week, associated with daily episodes of fevers and drenching night sweats. He denied any weight loss or any recent infections. He works on a cruise and denied any recent exposure to sick people or pets. Now, the previous week, he received a course of antibiotics without any resolution of the symptoms. Most of the labs came back normal. The urinalysis showed proteinuria, large amount of blood and mucus. But he denied any urinary symptoms. The CT scan of the neck showed extensive left cervical lymphadenopathy and regional soft tissue inflammatory changes. Initially, he tested positive for HIV, but the repeat test came back negative. Now, the patient was treated with supportive therapy while we were trying to figure out what was going on. We consulted infectious disease and nephrology, and a cord needle biopsy was recommended to rule out any ongoing infection process versus possible non-Hodgkin lymphoma. Both core biopsy of the cervical lymph node and also a kidney biopsy were performed. Core needle biopsy came back positive with histological findings resembling Kikuchi-Fujimoto disease. Since the patient had two abnormal urinalysis, also we performed a kidney biopsy and was consistent with IgA nephropathy. Now, even though this clinical presentation of cervical lymphadenopathy, daily fevers, drenching night sweats should raise the concern of malignancies such as non-Hodgkin lymphoma, there are still other infectious processes that can cause this and that should be ruled out first. Our initial labs were mostly normal. LDH was high, but there was apparently no inflammatory process going on, raising the suspicion of non-Hodgkin lymphoma. Now, the core needle biopsy confirmed Kikuchi disease, and the kidney biopsy was indicative of IgA nephropathy, two separate entities. Now, we conclude that because a viral infection can trigger IgA nephropathy, once Kikuchi disease resolves, IgA nephropathy should also resolve. Now, the patient serologies were negative for mostly all kind of viruses that we can test of. And this is definitely an interesting case report that highlights the need for further investigation into the etiologies of Kikuchi-Fujimoto disease and possible related syndromes.